Let's go with my disclosure for. Beyond the frailty assessments, because you have evaluate your patients, and now you have to choose the right treatment. It's only a question of doublet or triplet. It's a question of dose of every molecule. What we have learned from the past, MPT, you say MPT, but not all the MPT are equal. That's what we learned from the Precedent trial with the MPT. Thalidomide, 200 milligram or 400 milligram, like it was planned at the beginning, or 100 milligram is not the same. The dose of melphalan is not the same, and it impacts in the results. And the major fact is the result from the Nordic group, the first trial with the MPT, there was no benefit in overall survival. And then the trial from the IFM, and we reduced the dose of alkylating agents, and we reduced the dose of thalidomide for patients older than 75 years of age, and we have good results, and we have better results in overall survival. And also, the other example is the MM015. It was the association of melphalan, prednisone, and lenalidomide, and then lenalidomide to pursue, comparing to MP. There was big results for patients between 65 and 75 years of age, but it was not so good for patients older than 75 years of age. If you are not right in the dose of the molecule, you won't have the result that you want, that you expect. And there's a big difference, especially with the cumulative dose intensity for patients older than 75 years of age. At this time, there was no geriatric assessments, but we have only the age, but we have seen that it's an important fact, even if it's only the same, the only one. And you have toxicities with neutropenia and febrile neutropenia at all. And if you don't treat like you want, you won't have very good results. So for frail patients, it's very important to choose the right treatment, and also at the beginning, because the first 3 months of treatment are crucial. That's the time you keep patients under the treatment, or he will escape. And in the first trial, the dose was adapted for lenalidomide only on renal function, but for dexamethasone it was adapted for patients older or minus 75 years of age, and also for the alkylating agent, and also for the thalidomide. And it was in this trial, you know that there was 36% of patients older than 75 years of age. It was not real life, but it was approaching. So now, beyond frailty assessment, what is the collaboration in frailty patients with the geriatric units? In my point of view, I don't wait for geriatric to tell me how to treat patients. I have to decide. I know the treatment, I see the patient, I have to decide it. But then, during the first 3 months, the first 6 months of treatment, when comorbidities, even, for example, diabetes, hypertension, they will move with the treatment. And you need a collaboration. You need to follow the disease with the hematologist and the other side of the patient and comorbidities by the geriatrician. You need collaboration. You don't need the geriatric to tell how to treat, but to help you to treat what is doing wrong with your treatment. And that's the point. That's the gray zone, the unfit. It's easy to tell when you see the patient who is fit, who is frail, even if it's skating or the athletes. I like the athletes. But you can move very quickly. For example, the woman in the wheelchair, perhaps 2 weeks ago, she was performing skating and she fell and she has a fracture. And then the good one, after 1 month of treatment with lenalidomide, she's dizziness. She has bradycardia. She fell in the bathroom. She was hospitalized. And she performed pulmonary embolism, an infection. Sometimes it's like the way in the first 3 months, you can move quickly to one or to the other side. What we learn for the patients, when they are frail, you have to learn about them. There was a myeloma French survey for patients in myeloma about their experience. And there was more than 600 responses. There were two arms, patient coming from the French Patient Association and patient coming from the hematologist. And the important fact is that myeloma never forget me. 76% of patients, but also frailty, never forget me. You will be frailty until the end, and you have to manage the two sides of this problem. And then, so when you are frail, you have to adapt your treatment. And if you adapt correctly, you can keep on the treatment. And those reductions, for example, in thalidomide, in lenalidomide and thalidomide, was not so big for patients older than 75 years than patients minus to 75 years of age, because the dose was correctly chosen at the beginning. Now, how to manage adverse events. In first, for the major adverse event, even if you are old with myeloma, in 76%, you will die from your myeloma, and in only 25% from adverse events. About the grade 3 and 4 non-hematological treatment adverse events in the first trial for patients older than 75 years of age. There was infection, cardiac disorders, and fatigue, and then you would go less than 10%. And it was not so different from patients under 75 years of age. Now, the first complication, like always in myeloma, is infection. And it was studied by our colleagues from Italy. And there was a risk factor, the M component and the platelet count. And we know that it was the most severe infection in the beginning of treatment. It's at this time that you have to be very cautious with treatment. The first 3 months are always crucial. And it was also controlled in the first trial. And you see the incidence of infections at the top and the number of patients who present infection. And it's a maximum in the first, the 2, and the 3rd months of treatment. It was established also a risk factor with a low factor. It was a kind of protection with beta-2 microglobulin very low or ECOG 0, and then it's always the same. When you are frail, ECOG at 2, and you have a myeloma with adverse prognostic factors with beta-2 microglobulin, you have a risk factor of infection. And it was controlled, this to separate the two populations, and it was controlled in the MM015, MM09. It was a trial for established pomalidomide in relapse, and MM03 also with pomalidomide. And this kind of scale was confirmed in this trial. It can help to choose the patients who benefit from antibioprophylaxis. Also, thromboembolism, also when you are older, you have a maximum risk factor. If you don't move, you have more risk factors. If you have a big myeloma, you have risk factors. So it's always the case. And also we have to learn, even when you see the pictures of the trial, you saw adverse events, grade 3 or grade 4. But we know, for example, for the neuropathy, that we usually underestimate the impact for the patient in the daily life of some adverse factors, and especially for polyneuropathy. And when you imagine polyneuropathy, even in grade 1 or 2, for a frail patient, he will fail. And when he fails, you have a cascade of adverse events. Frailty and adverse event, usually it's not only one to treat. When you have one adverse event, you go for a cascade of adverse events. And also, I repeat, in the beginning of a treatment. Also, what is the experience of adverse effects in oral chemotherapy? What was a survey from the French institution in hematology and they address to the Association of Patients, and they compare chronic myeloid leukemia and myeloma. And there was 76% of side effects interfering with daily life and 80% of side effects interfering with daily life for the CML and for myeloma. And only in one half it was benign side effect. It was fatigue, neuropathy, digestive, and cramps for myeloma. And if you imagine if you are already frail, if you add fatigue, if you add neuropathy, it begins very difficult. And also about polymedication, because you want with frail patients to go for oral medication, but you go always for antibioprophylaxis, antithrombotic, and you add medication more and more. And myeloma treatment and complication, 5 to 6 pills per day. Comorbidities, 2 to 3 pills per day. Concomitant treatment, 1 to 2 pills per day. And also, you need geriatrics, but also you need pharmacists to look at this and to look interaction between all of these treatments. And for example, almost 40% of patients take until 10 pills per day. And you add more. It's like, I call the prescriptions against all. You put the computers and the paper goes out with Bactrim, cotrimoxazole, valacyclovir, antithrombotic, folinolol, and so on. But patients have to take this, and when you are old, you have mistakes. More pills, more mistakes. And if you took the double dose of antithrombotics, you can imagine. Now, what will we have with the new agents, the next generation? Because all the new generation of drugs can be applied even for frail patients. And carfilzomib, there will be the cardiovascular toxicity. Ixazomib, there was no neuropathy, cutaneous rejection, a problem of diarrhea and nausea. Pomalidomide is like the other IMiDs. And the monoclonal antibodies, it's very few about. There's only the infusion reaction, and if you project on the administration of subcutaneous, it will be very easy. Now there's also an impact of the schema of treatment. If you have PERS, it's every 4 weeks. But in the first 3 months, it's not only every 4 weeks. Usually, you have a call in the first weeks, and you have to be very cautious. But it's easier. And you think elotuzumab or daratumumab, it's weekly for 8 times, then twice monthly, and then after 6 months, once monthly. But you have to come. The good thing is you can also have a look on your patients for a very repeat time, like we used to do with the administration of bortezomib. And now, multiple myeloma is a double-phase disease, in my point of view. You have the characteristic of a chronic disease, continuous treatment, multiple venues to hospitalization or consultation, but it's still a dramatic disease with a vital prognostic factor. So don't forget, you don't look only the electrophoresis or MRD now. You have to think of your patients. Conclusion, survival is improving even for frail patients. RD is a new standard of treatment. And also, the important fact is a new platform for the future. We will have more and more frail patients to treat. It's a reality. We are now at a new era of risk-adapted treatment. We won't be treated all patients older than 65 years of age like it was in the recent protocol for all patients. We have to think and to choose about frailty treatment, but also regarding the myeloma prognostic factors. And we need dedicated trials, especially for frail patients, and there will be one in the IFM trial. An IFM trial will compare lenalidomide plus daratumumab on subcutaneous way without dexamethasone versus lenalidomide plus low-dose dexamethasone. And just to Marseille qualify for the final, but I don't like so much Rolando, even if he scored important goals, but it's easier to go with a new team for the next year or the 2 next year, because some patients don't sign the contract. And some players also, you can play with them only at the 80 minutes. That's not so far. But I play with the oldest team. It was not so easy. But you have to be sponsored by the Qatar or all, because the cost is increased. And it's an important fact. You cannot just sweep this for the frail patients. The cost by month for a patient older than 80 years, it's a real question. I don't want to choose when I see the patients in front, but we have to think about society. Thank you.